Okay, good morning, everyone. I think we can start. It's already about 8:05. Okay, my name is Mr. Ian. I'm the HPB consultant. Today, I think for the CPC, we have a case which is multidisciplinary in nature, talking about Hilar cholangiocarcinoma, for those of you who don't know. So I think that we explain a little bit more. Hilar cholangiocarcinoma is basically cancer of the bile duct, but within the bifurcation area. Okay. So this is not a common case, not something you see from a day-to-day basis, but I think it is worthwhile to know and understand a little bit what are basically the treatment modalities that we have that we can offer to the patient. So I'd like to thank our panel today. We have Dr. Mogaraj, my registrar from my team, and Dr. Kishore, specialist in HPB unit. We have Dr. Isa from Interventional Radiology and Dr. Azyani from Pathology. Okay, so we were talking about a few components, basically from the initial diagnosis all the way to the management. Okay, maybe we'll take questions at the end if you have any questions at all. But I think without delaying much further, we will start the presentation. I can invite Dr. Mogaraj to do the case presentation.
Good morning, everyone. I'll be presenting on the case presentation. So this is actually a 61-year-old gentleman. He actually asymptomatic. He went for a medical checkup in Pantai, and then the Pantai Melaka. Then he noted to have deranged LFT and raised CA 19.9. Otherwise, he's asymptomatic. During this time, also he was diagnosed to have hepatitis B. So you can see the CA 19.9 was 42, and the ALP was deranged, and ALT and AST also deranged. So he have transaminitis, but the bilirubin was not deranged. So otherwise, clinical examination was unremarkable. He had no significant physical findings on our clinical examination. So later on, we investigated him. We did a few series of investigation. We did MRI liver. So we noted to have a mass at the hilar region with biliary dilatation. So we subsequently proceeded with the CT scan. So which noted to have a close proximity to the right hepatic artery. And then the MRCP diagnosed to have an obstructive clad skin tumor with a local regional extension. So it's a bismuth, call it type 3A. So our impression was hilar cholangiocarcinoma. So as we discussed with the images just now, so roughly at the circled area, that's the tumor site. So before embarking on the surgery, so we proceeded with the transhepatic embolization of right portal vein in view of the future liver remnant was 31%. So after the embolization of right portal vein, so the future liver remnant was 61%. Patient underwent open right hepatectomy, caudate lobectomy, cholecystectomy, and lymph node dissection with a HJ recon on the December. So post-operatively, patient recovered well, and during surgery also we sent a frozen section of left intrahepatic duct and distal CVT, which will be further discussed later. So the HPE came back as right hepatectomy with intrahepatic cholangiocarcinoma is well differentiated, TNM classification T1A, and there was a perineural invasion with by the malignant tumor, and margin was clear. So no lymphovascular invasion was identified also. So post-operatively, patient recovered well, and currently he is under treatment with the oncology team planned for adjuvant chemotherapy. Next will be presented by Mr. Kishore. Yeah. Radio first, sorry. Dr. Isa.
Okay, just for your learning purpose. So you realize that this patient, we jump straight into investigation. Of course, this patient, as you have learned, usually we talk about history and physical examination first, but just so happened that this patient went for medical checkup, right? And they noted there was a deranged liver function test. And because there were no symptoms whatsoever, you cannot really present. Okay, of course, but in your case, when you see a patient, you always start with the history and physical examination first. Okay, so I think basically this was a patient, if you have seen for the first time, you would have worked up based on the liver function being deranged. Okay, you may have a few differential diagnoses in mind, but in this patient, as most patients, as you know, this patient had very early stage of cancer, so there were no symptoms whatsoever, right? Just a derangement in the liver function. So you will come across these patients in the future where they just come with deranged blood investigations, and you have to work up from there, okay? Because in this day and age, there are a lot of patients who go for medical checkup, and they find things from the medical checkup, but not necessarily have any symptoms, right? So this patient from the workup, probably they might have done ultrasound first and found that there were dilated ducts and basically proceeded with further imaging. So the next modality of imaging, sometimes we do CT scan first, but in this case, I think because they saw the ducts dilated, they did a MR liver, MRCP. Okay, and they noted there was a tumor in the bifurcation of the bile ducts. Okay, so a CT then was done after that, because in our case, we need to plan for surgery. While we can use an MRI to look at vasculature, it's not the best. So a CT scan is helpful to help us do some planning for the surgery. Okay, so now what was quickly discussed just now was the future liver remnant. You guys know what that is? So after we resect the liver, there must be adequate liver for the patient to survive, right? Anybody have any idea how much is enough? Anybody? How many percent do you think is enough for a patient with normal liver? How much percent of liver can you survive? If any of you so happens need to remove your liver, how much percentage of liver can you survive on? Anybody? 10%, 20%, 30%? Okay, let's go. 10%. How many will say 10%? 1, 2. 20%. A few more. 30%. More. Okay. So if the liver is quite normal, 20% to 30% is good, right? If the liver has some form of congestion, 30 to 40, up to 40% will be better. Okay, so cirrhotic livers living about 40%. This is by calculation of volume. Okay, all right, I'll pass over the time to Dr. Isa.
Thank you, Mr. Yan. Sorry for the delay. So, as been mentioned by our first speaker, so this patient we diagnosed as Hilar Cholangiocarcinoma. So, the treatment plan that was given or discussed in a conference, so they're planning to do a right hepatectomy. And then for pre-op optimization plan, so we're going to increase the left liver lobe volume. By how we can achieve that is by doing a portal vein embolization or more specifically right portal vein embolization. So this is the clinical problem. Major hepatectomy risks liver failure if functional liver remnant or FLR is inadequate. So by doing a portal vein embolization or PVE, we tend to increase the FLR preoperatively. So if you look at this one, this is the blood supply of the liver. So we know that the blood supply to the liver is dual supply, which actually coming from hepatic portal vein, around 75%, and 25% from the hepatic artery. So the idea behind the portal vein embolization is that you want to reduce the blood supply to the right side. You want to kill that off slowly so that to let the left side becomes bigger for it to take or to compensate the work of the right side that you're going to chop off later. So based on that idea, we are going to cut the supply from the portal vein, so only left 25% supply to the liver. So the right side will shrink and allow the left side to increase. So this is the CT that was done in private hospital. The diagram and then how they measure. So a bit small here, but we can see somewhere around here, it measures the left liver lobe volume is only 35%. So 65% being taken by the right side and another 35% taken over by the left side. So what we're going to do now is that we're going to cut off the supply to the right side, let the right side shrink and the left side become bigger. So post-operatively, the liver is good enough to cover the job of two supplies. So what what we did was we puncture from this is the what we call as angiogram. You can see here, sorry. So this is portal vein angiogram. So you can see the catheters coming from here, and then we did an angiogram showing the portal vein, portal contrast within the portal vein. So this is at the level of the main portal vein, and so this one is the main portal vein. This is the right side, and this is the left side. So you want to kill off this part of the liver. All right. So we give a glue. In this case, we chose to give a glue. So this is how the glue looks like. So you can see that we inject the glue, and the glue fill up in this space and try to block all the blood supply inside the right portal vein. Okay. So you can see the contrast here in the kidney. So glue, when it interacts with the blood or inside the blood vessel, this is how it looks like. So we have glue, you contact with blood, they can harden, will harden like this, and automatically will thrombose or block off the supply. And this is the image post-procedure. You can see that it's very nicely covered. As you remember the earlier image, this is the main portal vein, left side and the right side. So the entire right side has been filled up by the glue. There's no more flow into the right side. And this is the another image. So this is not contrast actually. So this is a glue with contrast, and this is the reconstruction CT. And you can see that's a beautiful crystal-like glue inside the right side of the liver. So post, if you compare pre and post portal vein embo, so this is pre-embo and this is post-embo. You can see clearly there is a demarcation between the right and left side. So left side initially was only around 35%, and then the left side now becomes 60%. So it makes easier and better for the surgeon to go in and do the hepatectomy. Thank you.
Next is Dr. Azyani, then followed by Mr. Kishore. Just put the slide. I think should be okay. This one another.
Okay. Assalamualaikum. Good morning to everyone. Okay, so I'll be presenting the frozen section specimen sent for this patient. This is the clinical history written on the request form. 61 years old Chinese gentleman with clad skin tumor 3A. He underwent MRCP, showed obstructive clad skin tumor with local regional extension, and he underwent open right hepatectomy, caudate lobectomy, cholecystectomy, and lymph node dissection. Okay, the specimen sent for frozen section include A, distal common bile duct, B, left intrahepatic duct, and C, bile duct. So the frozen section specimen is a fresh tissue that is taken intraoperatively. Okay, before we move on, I just want to briefly show you the normal histology of bile duct. Okay, so it is a tubular tissue. So this is part of the common bile duct. Okay, so this common bile duct is lined by simple columnar epithelium. So you can see the nucleus is uniform. Okay. And then it's lining this tubular structure. Okay, so this is the lumen of the bile duct. So this is normally the normal histology. Okay, now we move on to the specimen sent for this patient. So from specimen A, it is labeled as distal common bile duct. Okay, so this is the frozen specimen. So you can see here tubular tissue. So this is part of the bile duct. Okay. So it's a tubular tissue. So this is the lining epithelium of the bile duct. Okay. So it is in most areas lined by simple columnar epithelium. However, at the area that I marked, there is some dysplastic changes seen. Okay. higher magnification. So this is the higher magnification of these areas. So you can see here the nucleus is more enlarged, okay, hyperchromatic, and it has become a bit stratified. Okay, so this is the areas that concern us during the frozen specimen. Okay, so this is the area that we say it is low-grade dysplasia. However, there's no deeper invasion seen. The tissue, okay, the frozen tissue, after the frozen section, so we'll fix the frozen tissue, okay, the fresh tissue and in formalin, okay, to be analyzed by routine HPA, okay. So this is the paraffin section of the same tissue. So here is the common bile duct, okay. It is lined by similar epithelium, simple columnar epithelium. However, we don't see anymore that low-grade dysplasia area. So here, this tissue is lined by simple columnar epithelium. There is mild papillary infolding. However, there's no obvious nuclear stratification or enlargement seen here. Okay, so there's no atypia and no invasion observed. So the final diagnosis for specimen A is negative for dysplasia or malignancy. Okay, specimen B, okay, this is the fresh tissue sent from left intrahepatic duct under frozen section. So you can see here fibrocollagenous tissue. There is stromal infiltration by these malignant cells. Okay, here the area that I marked. Okay, so the cells, they are arranged in infiltrating cords. Some are forming small ducts. Okay, some are forming nests, and there are occasional single cells as well. Okay, so this malignant cell, they display moderate nuclear pleomorphism. So the nucleus is a bit enlarged, okay, and hyperchromatic, and there is moderate cytoplasm. So we can see occasional mitosis as well. Okay, again, higher magnification, you can see here all these hyperchromatic nuclei. Okay, this is the malignant cells arranged in infiltrating cords, small ducts, and nests. Okay. And then the tissue underwent formalin fixation. Okay, so this is what you see. Again, similar fibrocollagenous tissue. There is malignant cells infiltration. So in this area, okay, again forming infiltrating cords, small ducts, and occasional single cell. So the final diagnosis for specimen B is malignant cell seen. Okay, so for specimen C, labeled as bile duct, okay, so the frozen tissue, it shows a fibrocollagenous tissue, so there are some atypical cells infiltration, they are forming glands, okay, and occasional small nests within this fibrotic stroma, and the cells, they display mildly enlarged nucleus, okay, and hyperchromatism with moderate cytoplasm, however, there's no mitosis seen. Again, higher magnification. Sorry, this is other areas. Okay, so again, fibrocollagenous tissue, so showing some atypical cells infiltration, forming glands in areas. Okay, and occasional infiltrative nests. Okay, and they display mild atypia. So the tissue underwent formalin fixation, and then we analyze again. Okay. Similar morphology, okay, fibrocollagenous tissue showing lobules of atypical cells, okay, they are forming glands and occasional small nests within fibrotic stroma, okay. The cells display mild to moderate nuclear pleomorphism, hyperchromatism, and moderate cytoplasm, no obvious mitosis. So our impression for specimen C is atypical cells seen. So our final diagnosis for A, okay, distal CBD, negative for dysplasia or malignancy. Okay, for B, left intrahepatic duct, malignant cells seen. And for C, bile duct, atypical cells seen. So here I'm going to talk a bit on intraoperative frozen section. So this is used for rapid diagnosis of tissue biopsy intraoperatively. Okay. So this result of the frozen section will help the surgeon to plan the intraoperative management of the patient. Okay. So a bit on the procedure. Okay, so surgeon will take biopsy during operation. So this fresh tissue is sent to lab immediately. Okay, and then the tissue will undergo processing by freezing it with frozen aerosol spray. Okay, and then the tissue is sectioned using this cryostat machine. Okay, okay. So the cryostat will freeze the tissue, and then slicing of the tissue for microscopic section. Okay, so the temperature of the machine is -20 to -30 degrees Celsius. Okay. So the frozen water in the tissue will produce a hard matrix that facilitates the slicing of the tissue. Okay. Then the sliced tissue will be mounted onto the glass slide and then undergo hematoxylin and eosin staining. Okay. And then it is ready for analysis by pathologists in charge. Okay. And then the results of the frozen section will be conveyed immediately to the surgeon in the operating theatre during operation. Okay. Okay. This is the cryostat machine. Okay. It has a freezing chamber, a microtome plate. Okay. And then this is the chuck to hold the specimen. And then this is the control panel to adjust the temperature and the thickness of the tissue being sliced. Okay. Okay. This is the chuck here. So you can see here this tissue, this red tissue, and then this is the this tissue is being frozen, okay, and then mounted onto this chuck here, and then this is the microtome blade to slice the tissue. Okay. Okay, so the tissue slices will be mounted onto this glass slide, and then we'll stain the tissue with hematoxylin and eosin, and then this tissue is then ready for analysis. Okay, so the overall process from the specimen arrival at the lab to the release of the result takes about 40 minutes to 1 hour, depending on the complexity of the specimen. Okay, so it provides a rapid diagnosis compared to the routine formalin-fixed paraffin-embedded technique. Okay, however, it is still inferior due to its many limitations. Okay, I'll be going through this limitation later. Okay. Frozen section should not be treated as an emergency request. So it is ideal to make appointment at least a day before the operation. Okay. In most labs, it is not done after office hours. Okay, close cooperation between surgeon and pathologist is required for a meaningful frozen report to be achieved. Okay, so the cases should be discussed beforehand. So we need ideally to be discussed a day before, okay? And all the relevant patient information is conveyed, okay? The clinical history, previous diagnosis, type and site of the specimen that will be sent, okay? And the purpose of the consultation, okay? And then pathologists should decide whether the frozen section is worth pursuing, okay? If not, it is safer and wiser to wait for the proper histopathological assessment of the case through the routine formalin-fixed method. So these are some of the indication of frozen section. Okay, to establish the nature of the lesion, usually benign versus malignant, to establish the presence of the lesion, to confirm sufficient tissue is present for diagnosis, okay, assessment of surgical margin as in this case, okay, establish the evidence of invasion, determine the presence of infection, for example, granuloma or fungal bodies, okay, and then lastly to acquire fresh tissue for special study. Okay, these are some limitation of frozen section. Okay, first is sampling error, include poor sampling of the tissue, poor selection of the appropriate tissue during grossing. Okay, for example, if large tissue is sent and then the pathologist has to use discretion to sample the most representative areas. Okay, if extensive tissue degeneration or necrotic tissue being sent, okay, so we cannot see the viable area for assessment. Another limitation is technical problem, include freezing artifact on the tissue specimen. Okay. A poor quality tissue section, okay, for example, the tissue is too thick after sectioning, okay, or there's tissue folding, so we cannot assess the morphology. Presence of air bubbles in the tissue section, okay, and difficult to cut tissue. For example, adipose tissue, so it cannot be cut during frozen, okay. Another thing is bloated cell morphology and polystain tissue section. All this will give us difficulty in analysis of the tissue. Next is interpretative error, okay. For example, tumor cells may mimic normal structure. For example, the signet ring cells versus macrophages, okay, in the tissue. So we cannot differentiate this. If the tumor is mixed or have biphasic in nature, okay. For example, in teratoma, so this immature component not sampled, okay. If tissue has variable degree of tumor differentiation, for example, in brain tissue, glioma, okay, the high-grade areas are not sampled. In cases of chronic pancreatitis versus pancreatic carcinoma, so these are the histologic mimic, okay. And then another thing is in H-prong assessment, okay, so difficulty in assessing ganglion cells and hypertrophic nerve bundles in frozen section. Okay, these are examples of tissue artifacts seen, okay. You see here, this is the frozen tissue, okay. There are cracks and open spaces, okay, after the tissue is being cut, okay. This is due to freezing artifact of the tissue. Okay, tissue folded, okay, so we cannot assess this area. Presence of air bubbles in the tissue, okay. And again, freezing artifact, okay, this is supposed to be stratified squamous epithelium, okay. And then bloated cell morphology. So this is what happened in our case, okay. The specimen A that was diagnosed as low-grade dysplasia, okay, because the cell looks a bit enlarged, okay. Okay, contraindication of frozen section. There is no absolute contraindication. However, certain limitation and precaution should be kept in mind, okay. For example, in this case, unnecessary but not harmful, okay. Example, frozen section of a large tumor in which there will be no changes to the intraoperative management. So better to send tissue as a routine formalin fixed specimen, okay. Frozen section on a small primary lesion that will be frozen in their entirety, okay. So this frozen artifact or loss of tissue could hinder proper tissue analysis later, okay. Frozen section on pigmented skin lesion, okay. For example, melanoma versus nevi, okay. This is due to diagnostic challenges, okay, and limitation in margin assessment. And then cases of infectious disease, okay. For example, suspected tuberculosis. So this will lead to exposure to the pathogens while handling the fresh tissue. Okay. Lastly, okay, so frozen diagnosis and assessment can be tricky and difficult. So we must be aware of its indication and limitation. So pathologists will try to give the closest diagnosis possible to the surgeon to aid in the intraoperative management. Okay, so definitive diagnosis, it's safer and wiser to wait for the proper formalin fixed tissue specimen. Thank you.
Where is it? Here, I will open it. Oh.
Okay, good morning, everybody. I'm Kishore, a surgeon in the HPB unit. So before I start, I'll just like to thank our invited guest speakers, Dr. Isa and Dr. Azyani, for imparting knowledge on how to manage, co-manage Hilar cholangiocarcinomas. Not only in this talk, but also with this patient, because if I'm not mistaken, this is the first time we did a portal vein embolization in UKM to augment the liver volume. And thanks to the interventional radiologists and the pathologists' help, the patient had a good outcome post-operatively, and now he's undergoing chemotherapy and hopefully lives a long, productive life. Okay, so I'll be wrapping up the morning CPC by going through an overview of hilar cholangiocarcinomas and specifically touch on future liver remnant and how to approach its augmentation, and also intraoperative strategies when dealing with a frozen section. Okay. So this is a very tricky topic to present and discuss in simplistic terms, but I'll try my best so that everybody at least gets an idea of what we can do when someone has a hilar or perihilar cholangiocarcinoma or Klatskin tumor. Okay, so by definition, it's an adenocarcinoma arising from the biliary epithelium at the confluence of the bile duct, meaning around the left and right intrahepatic duct. Okay, so it's also known as Klatskin tumor, and it's roughly represents 50 to 60% of all cholangiocarcinomas. So as you know, cholangiocarcinomas can be intrahepatic, perihilar, or extrahepatic, meaning distal cholangiocarcinomas. It is still a rare form of malignancy. Incidence is roughly about 1 to 2 per 100,000 patients. This is in the United States. Peak age is about 60 to 70. In, I think, the regional context, we see more of these hilar cholangiocarcinoma patients in northern Thailand, where liver fluke is endemic. Okay, so other risk factors include primary sclerosing cholangitis, choledochal cyst, which is a benign condition, hepatolithiasis, stones in the intrahepatic biliary tree. So to further understand how to manage cholangiocarcinoma, it's important that we know the classification. So this is a very famous classification for perihilar cholangiocarcinomas, the Bismuth-Collett classification. Essentially, it's divided into 5 types. Okay, so type 1 means it's just below the confluence, roughly about 1 to 2 cm below the confluence. Okay, type 2 is already encroaching the confluence, but it's not involving the secondary left or right intrahepatic ducts. Type 3 is already involving the intrahepatic ducts. So 3A, like in our patient's instance, is going to the right side. 3B is going to the left. If it's type 4, it's involving both left and right intrahepatic ducts. Or it's multifocal, meaning it's not continuously involving, but there are skip lesions. So it can be one maybe around this region, one here, one higher, and also on the left side. Okay, so presentation is not too different from most patients who come with obstructive jaundice secondary to malignancy. They'll have painless obstructive jaundice. In some cases, if they develop infection, they can have cholangitis, but it's less common unless they've already had prior instrumentation. Like in our patient, tumor marker was elevated. CA99 is usually elevated in about 85% of patients, but there can be false positives if patient has infection or obstruction. CEA is less specific, and normally we don't routinely take CEA as a part of workup for cholangiocarcinoma. Imaging, ultrasound is usually done for screening, like Mr. Ian said earlier. Usually if a patient comes with elevated liver enzymes or tumor markers or jaundice, the first line investigation is usually an ultrasound. At least gives us an idea where to direct the next modality of investigations. So if a patient has dilated intrahepatic ducts, biliary tree not readily dilated, bile duct, gallbladder has no stones, patient in the 6th, 7th decade of life, so our index of suspicion is higher towards cancer. The next line of investigation is usually triphasic CT. And this is essential not only to diagnose the problem, but is to help us to assess resectability. Because cholangiocarcinoma is notorious for a few reasons. One, although it's adenocarcinoma that involves the epithelium, the spread can be submucosal or within the layers deeper to the epithelium. And secondly, it tends to spread posteriorly, and the structure behind is the hepatic artery. So when it comes to the cholangiocarcinoma in the hilar region, our concern is the right hepatic artery, which tends to run behind the biliary tree. Okay, so MRI, MRCP is gold standard for us to delineate the anatomy and extent of the duct involvement. So this is where we can properly say which type of hilar cholangiocarcinoma, specifically what bismuth classification we are dealing with. So once the investigation is done, the next step is preoperative preparation. So it's paramount that the nutrition, physiotherapy, anesthetic review, and optimization of comorbids are done. Biliary drainage may be indicated in some patients, especially if they are jaundiced and future liver remnant is low. Okay, I'll get into the FLR later. And if they need augmentation, or if the patient has cholangitis, or if the patient has any condition that may predispose to delay of surgery, such as malnutrition. So ideally, PTBD is preferred because it allows for better mapping and lower infection rate, since we don't have to go through the gut as we would in patients undergoing ERCP. And we should drain the part of the liver that we intend to keep behind. There's no point draining in the liver segment that is coming out. Okay, so drain only the FLR. So once we've done part of the preoperative preparation is also to decide what type of surgery a patient will require. So normally the few core tenets when it comes to resection, one is, can we achieve radical resection, meaning we have margins that are free of surgery? Second thing is, if I'm going to resect the liver, is the future liver remnant adequate for the patient to survive? Because our biggest concern is not leaving the cancer behind, which may be possible, but the more worrying condition and more life-threatening problem will be post-hepatic liver failure. So these are the considerations that we have to take into account when we are dealing with perihilar cholangiocarcinoma. So basically, if you're talking about the types and what surgery we should consider, type 1 and 2, meaning is either near the confluence or just at the confluence, we may be able to get away with just resection of the bile duct and a cholecystectomy. But like I mentioned, the cholangiocarcinoma is notorious for submucosal infiltration, and it may actually be further high up or further more proximal into the bile duct than what we can see from imaging. The radical resection that may be preferred is right hepatectomy or left hepatectomy and caudate lobectomy. Why we say right is preferred to left is because for a few anatomical considerations. One, I mentioned earlier, the right hepatic artery runs posterior to the biliary confluence. Second thing, the left intrahepatic duct has a longer course outside the liver, right? So it gives us more room, more buffer for us to resect and anastomose if necessary. Okay, so for 3A, 3B, basically it depends, because 3A is going to the right side, we will remove the right, so preferably right, extended right, meaning segments 4, 5, 6, 7, and 8. Okay, segments 5, 6, 7, 8 is the right lobe, 2, 3, and 4 is the left lobe. But if we're talking about extended right, meaning we include segments 5 to 8 and also segment 4A, 4B. For 3B, meaning is the tumors to the left intrahepatic ducts. So we'll do extended left, meaning 2, 3, 4, and segments 5 and 8. So you'll see here that I've put segment 1, which is the caudate lobe, for all resection. Why we resect the caudate lobe with hilar cholangiocarcinoma is because the biliary drainage from the caudate lobe is directly into the left and right intrahepatic ducts at the confluence. So if there's cancer, there's a likelihood that cancer would have already spread into the biliary tree extending from the caudate lobe. So we have to resect the caudate lobe as part of radical resection for oncological clearance. Unfortunately, for bismuth type 4, where it's spread into the left and right intrahepatic ducts, most of the time the prognosis is quite poor. Resection is very limited. It's only done in very highly specialized centers where they see large volumes of patients. There are a few protocols that some centers adapt. Like in the US, Mayo Clinic, they actually give a round of chemotherapy, radiotherapy, and then consider patients for transplant in small tumors around the perihilar region for type 4. In larger centers, some of them, they resect just the center, meaning segment 5, 8, 4A, 4B, if the tumor is confined to that region, and do multiple duct anastomosis. So a lot of centers, but there's no one size fits all plan for hilar cholangiocarcinoma involving both left and right ducts. And in our experience, normally when they come, it portends a very poor prognosis, and patients normally not fit for any major resection. Okay, so I'll move on to the next part, which is, Okay, so now we know that one, we want to resect and make sure the patient's cancer-free from during the resection, meaning oncologically resected. The more important thing is whatever liver is left behind should be enough for the patient to function and survive on. Okay, so assessment of future liver remnant is very crucial before we embark on any major hepatic resection. Okay, so it's the most critical predictor of post-hepatectomy liver failure, which is the primary cause of mortality and morbidity in extensive liver surgery. So there are two modalities that we assess. One is volume, which can be done using 3D reconstruction from CT or MRI scans. Dr. Isa had showed earlier about how our patient had a volume of 35% prior to augmentation of the liver volume. Okay, so how we determine the future liver remnant is we take the total liver remnant and then we divide by the FLR from the total estimated liver volume. Okay, so safe thresholds is like we discussed earlier, Mr. Ian said, healthy liver 20 to 25%. If patient had chemotherapy or has cholestasis, 30 to 40. Any patients with liver cirrhosis that we are considering for surgery, usually be Charles A or good Charles B, less than 8, usually should go for at least 40%, so that they have a safe recovery, low risk of PHLF. Okay. Apart from volume, sometimes this can be a bit misleading because in diseased liver, it may look large, but because it's disease, is it necessarily functional? Not necessary. Okay, so there's also the option of checking the functional assessment. So indocyanide green clearance can check the excretion function of the entire liver, or technetium-99 hepatobiliary scintigraphy. So this is a nuclear study where we can do selective quantification of the excretion function. So we can just check if we're going to cut out the right side, what is the excretion function of the left side, and is that adequate for patient survival? So all these things can be done as an adjunct to just checking the liver volume. Okay, so like I mentioned, if normal adults, 20%. If there's damaged liver, fatty liver, or patient underwent chemotherapy, 30 to 40. Cirrhotic, at least 40%. So in our patient, he had Charles A liver cirrhosis and also hepatitis B. He wasn't jaundiced, and given that our population's incidence of fatty liver is quite high, we took the presumption that he falls under the category of damage or early cirrhosis. So we aimed for at least 40%. So fortunately, it went up from 35% to 60%, right, in the segment 2 and 3. So that is about why we need to do, why we need to assess future liver remnant, essentially is to prevent liver failure after surgery. What are the methods we have to augment or to increase the size of the remaining liver? Okay, sorry, I know this slide is very busy. I just wanted to I'll just go through quickly. So what we did, and the standard for liver augmentation is a portal vein embolization. So usually it takes about 4 to 6 weeks before we can see growth about 30 to 50%. Okay, so it has very low complication rates. Okay, but the cons is because we have to wait up to 4 to 6 weeks, the cancer is essentially given time to progress. Okay, but some cases, if we reassess after 3 weeks, patient looks fit, then we can already arrange for surgery early. Okay, so it's looking at balance. We cannot dictate what the tumor biology will be, so we have to try to make use of whatever time and try to make sure that the OT preparation, everything is done early, not planned at the last minute. Okay. Some centers, if you're planning to leave behind the left lobe, in Japan, actually, they have their own protocol where they, apart from doing the portal vein embolization on the right side, as we did for our patient, they also embolize the segment 4, which means the extended right portion, 5, 6, 7, 8, and 4 is angioembolized. So this gives additional growth of the segments 2 and 3, which will be left behind. We are doing an extended right hepatectomy. Okay, so this is not universally adapted for resection of the right or extended right. Okay, so it's done mainly in Japan, but it's shown very good outcomes. Okay, the newer, more novel technique in FLR augmentation is liver venous deprivation. So the unique thing about the liver, it has dual venous supply, the portal vein and the hepatic vein. So we can embolize both the portal and the hepatic vein of the segment that's going to come out. Okay, so this significantly increases growth rate of the segment that is going to leave behind, the FLR. Okay, but it's technically demanding and there's risk of exacerbating cholangitis. Okay, so one more surgery that's not commonly done, and there's some relative contraindications in cholangiocarcinoma, is ALPS. So it's associated liver partitioning and portal vein resection. It can cause very good hypertrophy of the remaining liver. Okay, but it's a stage procedure. So the first time we go in, we operate, divide the liver without removing it, and then ligate the portal vein of the side that's going to come out. Then after 1-2 weeks, go back in and resect the liver once the future liver remnant has hypertrophy. Okay, but usually it's not used in all PCCA cases because it's increased risk of morbidity, mortality, okay, because of sepsis, bile leak. Okay, and the patients generally, when they're jaundiced, it's very high risk to go in for stage surgery. So it's not commonly done for cholangiocarcinoma. It's reserved more for patients with metastatic colorectal, liver metastasis, and so on. The newer ones like transarterial radioembolization is also emerging. It's very niche. Okay, it's usually primarily as bridge for surgery, but they have to wait 3 to 6 months to give time for the radiation and wait for the biliary toxicity to resolve. Okay, so this is portal vein embolization, like Dr. Isa showed earlier. So we just embolize the segment that is going to be removed. Okay, liver venous deprivation, meaning we block the hepatic vein and also the portal vein, so that this one grows even faster than in a standard PVE. Okay, so ALPS, associating liver partition and portal vein ligation for stage hepatectomy. So like I said, we divide the liver and cut off the portal vein on the side that is coming out, come back in after the hypertrophy has set in, and then we remove the liver that has the cancer. Okay, so it's a 2-stage procedure. Then the other one is the transarterial radioembolization and radiation. Okay, so they just put in microbeads that emit radiation into the tumor cells itself. Okay, so those are the methods. So normally, and what we've done here is just portal vein embolization, but it's just, I think, probably enough for everybody to know there are other options apart from PVE. So it depends on what is the requirement. So it's patient to patient basis. Can we wait? Do we need to do it faster? Okay, so these are some technical considerations to take into account, and also patient factor. Okay, so once we've augmented patients' FLR is more than 40%, the next step is to remove, and then this is where the intraoperative decisions are very imperative to make sure the patient has good oncological outcomes with no post-hepatic liver failure. Okay, so this is where frozen section is very crucial. So it helps us to decide on table whether are we happy with the margins that we've taken, or do we need to resect some? Okay, so the goal is always R0 or R0 resection to have the best oncological outcome. But you have to balance this against resecting too much of the bile duct until the point you have to resect the liver, and the patient has inadequate liver volume, develop post-op liver failure, right? So it's a balance between oncological resectability and liver failure. Okay, so sorry, I think my slide is moved a bit. So basically, when we are doing a typical resection, for example, like our patient was a extended right hepatectomy, caudate lobectomy, and bile duct excision. So these are the margins we normally send. So proximally, the arrowhead, this is the proximal biliary margin. So this was the right intrahepatic duct. Distally, we will send the distal biliary tree, so closer to the pancreatic head. Okay, and like I mentioned, the vessel hepatic artery is posteriorly. If it is involved, we may have to resect and reconstruct. That hepatic artery wall also has to send for frozen section. Okay, in some cases, even the liver margin, if it is a very distal tumor or proximal tumor, very high up, sometimes we may have to send the liver margin, just shave the liver margin and send for frozen section. Okay, so in our patient, we sent this portion here, the left intrahepatic duct and the distal biliary tree. So like Dr. Azyani mentioned, when we sent the first time, came back positive for cancer cells. Then we had to re-resect. Okay, so what happens if there is cancer on the frozen section? It would be nice if everything comes back, no cancer, then we know that we are safe to start anastomosing the biliary tree to the small bowel. But if it's positive, there are two things that we have to see. Which one is positive? Is it the proximal margin or the distal margin? So the one that's more problematic, the one that can lead to post-hepatic hepatectomy liver failure is the proximal margin involvement. So if it's positive, we can consider shaving another 5 to 10 millimeters. So this is why I mentioned about our preference to remove the right lobe compared to the left, because the right hepatic duct has a longer route, and also it's longer in general compared to the right side. Okay, so we have more buffer to cut if we need to shave the bile duct proximally. So how much we can shave? Another 5 to 10 mm, and usually we don't shave more than twice. Okay. So why we don't do it? Because if we cut any further, we may not have enough duct to sew back. It's already into the liver. Or in some cases, it's supposed to be one bile duct. You keep cutting, then you end up you see 2-3 openings. Or 2 openings if you're doing an extended right hepatectomy. So segment 2 and 3 bile ducts are separate. Then you have to do 2 anastomosis. Okay? So that is one problem. And like I mentioned, you keep cutting, then you may have to end up shaving or cutting the liver to achieve the margin, then patient can develop post-hepatectomy liver failure. Distally is you can continue resecting until the head of the pancreas. In extreme cases, if it's still positive, patient may require a pancreaticoduodenectomy, but this is major surgery in and of itself, and this can lead to higher morbidity and mortality rates because now you've removed the liver, pancreas, part of the stomach, duodenum, right? So it's a very long surgery, and it has its own complications which are amplified by the fact that you have to remove liver plus the pancreatic head. Okay, so does it matter if the frozen section was R0 initially or became R0 after the second resection, or is it positive? And you had no choice but to anastomose because you cannot go any further and risk liver failure. So if the initial frozen section is clear, that means you've achieved R0 from the start, it has the best overall survival. Okay, 5-year survival is about 30 to 40%, including adjuvant treatment in patient stage 1 to 2. If the patient has revised negative, meaning first one was positive, like in our patient, the second resection came back negative for tumor, it's R0 technically, but it doesn't have an outcome as good as an initial negative, right? Because the notoriety of cholangiocarcinoma to spread submucosally is a problem. Okay, so it may be skip lesions. It's significantly better than having a positive final frozen section, but it's not as good as an initial negative, so it's in between. Okay, but if the patient comes back with positive margin on the second frozen section, we still anastomose because we can always consider giving the patient adjuvant treatment like chemotherapy, right? But if the patient, you're chasing for negative margins and you keep cutting in and have to resect the liver and patient goes into liver failure, then that's the end of the story. Most likely the morbidity is going to be far higher than the benefit of having oncological resection. Okay, so you can give chemo in positive margins, but you cannot do so if patient goes into liver failure. All right? Okay, so I will conclude my talk with a few take-home messages. All right? So I know it's a very difficult concept to grasp readily, but these are a few things that I think we can try to remember. Firstly, it's physiology trumps oncology. So if a patient has hilar cholangiocarcinoma, they most of the time come jaundiced. We were lucky that our patient had a screening done and was picked up before he developed clinical jaundice. So in most patients, who do not go for early screening or only present when they're symptomatic, the first symptom is usually jaundice, which means that the liver is already primed for failure. Okay, so we try not to in this case, we have to keep our egos in check. Never sacrifice the minimum FLR and chase for R0 margin all the time. Okay, sometimes you just have to take that positive margin as is and try to treat with adjuvant treatment. Okay. Before we do augmentation of the remnant liver, biliary drainage should be done if the patient is jaundiced. So this allows for proper regeneration or increased rate of regeneration of the liver. So you cannot do portal vein embolization in a jaundiced patient without clearing the jaundice first, right? The liver won't regenerate, end up going into more complications like cholangitis, and that patient still cannot go for surgery. Intraoperatively, like I said, frozen section is a very critical guide for us to decide. If it's still positive on the first one, two shave limit is adopted by most guidelines and major high volume centers. So 5 to 10 mm each time. If it's still positive after 2 shaves, I think we just go ahead and anastomose, okay, and then deal with it later. If you can get a revised R0, resection is still a win because it's better than leaving behind an R1 frozen section. So if the first one comes back positive and it is still feasible to resect some of the bile duct, we should still do that and not accept the first shave and continue with anastomosis. If the remaining duct is long enough, we can still take a sample and then go in for the hepatico J anastomosis. Okay, so the last one is, although we've talked extensively about liver volume, like I mentioned earlier, in a diseased liver, patients with fatty liver, cirrhosis, or patient who's undergone chemotherapy where there's augmentation of liver function, functional assessment with technetium scan or ICD clearance should also be considered as an adjunct to help better estimate the chances of patient developing post-operative liver failure. So if, let's say, the patient's FLR before augmentation is 40%, but the ICD clearance is not great, or the selective clearance of the technetium 99 is not good, we should still consider doing embolization or liver venous deprivation to increase the future liver remnant so that they don't go into liver failure. So volume is not the final decision maker. So if necessary, you may still have to augment with functional assessment. Okay, very complex topic. Hopefully, some things are captured. So main thing is it's difficult to diagnose. It's quite rare. We see the classification before we decide on surgery. The main principle is try to optimize the patient preoperatively. Make sure the patient, if it's jaundice, we drain or decompress the liver. Surgical technique and physiology is very important. So core principle is we try to achieve R0 resection or oncological resection for the best outcome. If that's not possible, the more important thing is make sure the patient doesn't go into post-hepatectomy liver failure. Okay, so with that, I'll conclude my talk. Thank you very much. Okay, questions? Questions? Yes, thank you.
Okay, thank you very much. I'm Sharul, I'm a physician. This is a very interesting topic. This will definitely come up in the long case exam in ictisas if the patient is around. So I've got cholangiocarcinoma in my ictisas. So maybe the team can summarize for the benefit of the medical students, if they got this as a long case, what can they do? How can they plan at least few principles of management initially before the patient got into subspecialized care?
Okay, thank you, Prof, for the question. So basically, if the patient is coming for exams, I mean, we should look at any patient as how we would deal with them on a daily basis. So I think the most important thing is looking at how to approach a patient with jaundice, right? So the overall team will be approaching a patient with jaundice. I wouldn't, I think if it's an undergraduate exam or even in masters, it's not fair that we go into so much detail about how to manage cholangiocarcinoma, Hilar cholangiocarcinoma especially, to the level that I've discussed. This is mainly for theory, but always look at jaundice as a whole first. So try to determine what type of jaundice first we are dealing with. Is it prehepatic, hepatic, post-hepatic jaundice? So I think if my students are here, or those who are doing surgery now or in medical, you'll probably be familiar with how to go about approaching the jaundice, and then talk about if you're going into obstructive jaundice, the next step is to determine what is it likely. Is it stone or not stone, right? So even that, like we said earlier, this patient will come with painless jaundice. So any patient who comes with painless jaundice, then we are more concerned about malignancy. Okay. If you're talking about investigations, it's the same gamut of investigations that we normally take: full blood count, liver function test, and how to interpret to determine the type of jaundice, renal profile, and other investigations as required based on the history and examination. Specific for cholangiocarcinoma or cancer. Nothing specific, but we will refer a patient to the dietitian. So essentially, any patient who's going for major surgery, like in our institution, we actually send them for a prehabilitation clinic. There is a big, movement now for the past few years called Enhanced Recovery After Surgery, which actually focuses on peri and pre-operative rehabilitation, prehabilitation, and optimization of a patient's condition. So while there's no specific diet that is required, the idea is to just, not for liver, but nothing specific for liver or jaundice, but it's essentially making sure that patient gets adequate nutrition and calories and protein. So this will be dealt with in detail by the dietitian and the surgeon when we see the patient in the clinic before surgery.
Okay, so I think Mr. Kishore summed it up quite well. So you're going to get a patient with jaundice, probably, right, or deranged liver function. So you're going to determine what type of jaundice this patient has. So based on history and physical examination, you try to elicit if you can tell this is a benign or malignant cause, right? And from the investigation, you're going to work up for the same, right? So I think at your level, what you're going to do is first your diagnostic ability. For management-wise, I think whether this patient needs decompression, if they have infection, you treat it. A lot of the patients with this liver cancers don't actually have malnutrition because they probably still eat as normal. They don't have any kind of loss of appetite or loss of weight as compared to GI cancers. But of course, we do assess these patients if they have poor appetite, have been eating poorly for the past few weeks, then of course we will optimize them nutritionally. If they can tolerate orally, then we will supplement them with a diet. If not, then sometimes we may have to give parenteral. This is the same principle for all kinds of patients. But in particular, patients with liver cancer usually don't have malnutrition. So usually they don't need optimization. Okay, so diagnostic in terms of history, physical, how you work out the patient to differentiate whether this is which type of jaundice, whether it's benign or malignant. You will probably need to resuscitate this patient if necessary, especially if they have infection. Start antibiotics if they have an infection, but they need some form of decompression. So like in this case, ERCP is possible but difficult. We did a percutaneous drainage instead to decompress the bile ducts. So in summary, that's it. Yeah. Okay.